and we are coming up with the DDH or pediatric hip module, and we're going to discuss DDH below 1 year of age today. With me today, we have very eminent faculties to help us navigating through the navigating us through this topic. And let me. Okay, so we have Professor Federico Canavese from Italy. Federico is a very dear friend of mine, and I remember that when I joined SICKIs as a fellow, my co-fellow said Federico is a machine to publish, and I was mesmerized by his skills of publication. Currently, he's head of orthopedic department in IRCCS Institute at Genova, Italy. He had his fellowship training at Shriners, Portland, USA, and SickKids, Toronto. He has done PhD in spinal growth in animals in Switzerland. And you all will be surprised that he has published more than 300 papers in international peer review journals. He is also visiting professor at Shanghai, China, and he is honorary secretary of EPOS as European Pediatric Orthopedic Society. So thanks, Fed, for coming up and sparing your time at this early morning. Thank you very much.
Morning.
And
thank you.
So I glanced through my archives and I found this. So this is we behind SickKids at the Asian restaurant. Can you recollect it? So yeah, we had fortune to be with a bunch of very good fellows at SickKids, and this is our I think Mercer Rank Day where we had to dress up and Federico on the left. So it has been a great time. Professor Jayant Sampath, he doesn't need any introduction. Jayant has practiced in UK and US for almost 15 years before coming down to Bangalore and heading the Rainbow Children's Hospital. And Jayant has great training in Alfred DuPont Institute, Wilmington, Delaware, and Manchester Children's Hospital. So thank you, Jayant, for being with us. With this, we'll start. Yeah, we'll start today's session. One thing before we start, somehow I could not register for Zoom Pro, so my meeting might get closed at 40 minutes, and then we might re-log in. Okay, so I just got this message now. So I'll invite my fellows, Dr. Kunal and Dr. Vaibhav, to start presentation, and we'll take today's session is a case-based interactive session. So in the course, if you have any question, please raise your hand and we'll take. Otherwise, better keep yourself muted and keep your video off. Yes, Kunal, please.
Good morning, sir.
Share your screen. Yeah.
Good morning, everyone. This is the fellow academic round for the interesting cases of DDH below 1 year of age. We'll start with the first case. This is the 3.5 years or 5 months old female child who was born at full term by LSCS due to breech delivery. She was a first child and she was referred to rule out DDH because the pediatrician noticed a deeper thigh crease on the right side. On clinical examination of the child, we could not elicit any ortolani or Barlow maneuver, and there was identical limb length, and there was restricted abductor spread on the right side.
Right. So, Jayant, now with the increasing awareness about DDH, all the pediatric colleagues, they try to elicit the positive test signs, that is ortolani and Barlow maneuver. And once it is negative, they think that that child is not having DDH. Now, how commonly you find this provocative test to be positive in younger children in your practice?
Clinical instability is rare.
Exactly.
But I'm sure many children who are born, particularly girls, may have a clinically unstable hip, but these never get referred. And I agree with you that Balo and Ortolani requires a lot of experience. And I have seen, because I work in a children's hospital with a maternity unit, I frequently see these pediatric residents who are called for the neonatal resuscitation to the emergency LSCS sections, the way they do the Balo and Ortolani, and it is not, they are not properly trained. And we don't have baby hippie models in India, which is, I think, an essential part of the training to teach pediatricians how to do the Balo Ortolani. So I think as orthopedic surgeons, we should teach our pediatricians who work with us how to do Balo Ortolani, teach them the proper maneuver. But I feel many potentially clinically unstable hips are not really referred to us at the right time.
Right. So what do you tell your fellows or resident, Federico, which are the most alarming clinical sign which would lead you to the diagnosis or the doubt about DDH?
At least in our setting, what is going to be important first is to know that the asymmetric skin creases is not a primary sign for instability. On the other hand, what is really important is the search for family history, for positive family history. So rather than starting right away for the clinical examination, first is important to know whether this patient has a positive family history. Then, knowing that clinical instability, I mean, knowing that asymmetric skin creases is not a very specific sign. And then, of course, you have to rely on a good clinical examination. But this comes after the clinical history.
That's right. So as we all are aware that there are risk factors, there are warning signs, and there are positive test signs like a breech child, one of the twin deliveries, and a positive family history. These are the risk signs where one has to be very aware. And what I have found is an unequal abductor spread, or one side is abducting more than the other, is the most common clinical scenario I have found where we have found a DDH as a diagnosis. And as you rightly say, sometimes we see a deeper thigh crease, but there is no DDH, and sometimes equal thigh crease, and still they may have dysplastic hip. And of course, as Jan pointed out, the Ortolani and Barlow test, they are very not very common, and it's difficult to elicit after 4 months, and it needs a very precise clinical examination. Now, this family brought this X-ray, and the radiologist said that it looks like the right hip is dislocated. So my question to Jayant is how far you will rely on X-ray to diagnose DDH in less than 3 months old or 4 months old baby, Jayant?
So Kishore Molpuri and colleagues at the IHDI group, I think Federico may also be part of it, have described the IHDI classification. And I would encourage all fellows to learn about the IHDI classification, which uses the Hilgenreiner and Perkins line to describe 4 classes or 4 stages of DDH severity.
So Jayant, we are discussing that in a moment, but would you use this X-ray for diagnosis
no, at 3.5
DDH?
months. Yeah, I mean, it's obvious on this X-ray, But I think up to 6 months of age, until the trochanteric apophysis, apophysis starts to ossify, I think ultrasound is the recommended investigation. So at 3.5 months, I think ultrasound can be done. And I think it's much more sensitive than X-ray.
Right. Federico, what is your practice?
My practice is very similar. With this X-ray, you notice that the ossific nucleus has not appeared yet, so you can do an ultrasound. So actually for us, there is not an age limit for the ultrasound. What is important is the absence of the ossific nucleus, because what makes the ultrasound unreliable is the presence of the ossific nucleus. So if you have, let's say, a 4 months or 5 months old child with an X-ray showing that there is no ossific nucleus and you have doubts, like in these cases, you can do an ultrasound still, because the answer you will get from the examination will still be useful, because there is all cartilage, so the ultrasound can work well.
And when you, at what limit you don't, once you see the ossific nucleus, you don't get ultrasound anymore, right? Mostly after 6 months.
Yes, and also the important point, maybe the fellows should keep in mind, is that the ossific nucleus appearance in DDH is delayed compared to normal hips. So usually DDH side has a later appearance of the ossific nucleus, so you may still request an ultrasound at an older age.
Right. Fine.
So the reason the ossific nucleus is significant is because once the ossific nucleus appears, you can't see the acetabulum. So, and knowing where the triradiate cartilage is important to draw the lines. So that's why the ossific nucleus is significant for ultrasound.
All right. Agree. Let's move ahead, Kunal, and show what we got.
We got the static hip ultrasounds using the graph method, which thought out to find the beta angles, which came out to be the alpha was 38 degrees and the beta angle was 78 degrees, according to the graph class.
Now, can you go back to the ultrasound image?
Yes, sir.
Now, Jayant, we know that the graph has an extensive classification based on ultrasound images. What do you see on graph method of ultrasound? For instance, would you classify those hips, or you will just see that this is dysplastic hip and coverage is less than 50%? Do you go in details about the classification of graph?
I do, because it's important to go into the classification, because when you start treating these hips, you want to see if they are improving. So when you take an ultrasound at 2 weeks, you want to make sure that the angles are reducing, that a decentered hip, if it is a decentered hip, is recentering. So it is, I feel if you are going to use the graph classification, I think it's important to understand the classification in detail, because on follow-up, you want to make sure that the hip is improving, or more importantly, the hip is not improving. Because if the hip is not improving, then you have to abandon your current treatment and think about other options.
So Federico, do you prognosticate to the family based on graphs classification? Would you tell the family that this hip may not respond to the harness treatment, or you just don't go into details of classification?
No, we have a more light approach. So we don't prognosticate to the family at this stage, because usually we tell them something more depending if the hip responds well to the treatment or not. Whether the hip responds to the treatment or not is one of the main criteria then to tell the family this hip may go wrong, you may have some trouble or not. So at this stage, we see the hip is dysplastic, it requires a treatment, And this is all we say to the family. We don't go too much in detail. And then we see how the hip evolves over time. If the answer, if the hip responds well to treatment, then we tell the family something. If the hip is not responding, we tell the family something else. But we don't spend too much time with the family about
Federico,
the classification.
So if we log out of the meeting, kindly rejoin, okay? Because it seems that my pro version has not been activated. So if we discontinue, just please connect again. Yeah, Kunal, can you go further and show what happened and how we approach this? Yes, so okay, so sorry for that, and thanks for rejoining. Yeah, Kunal, you can share your screen and we can go to that slide. Yeah, Kunal, please share your screen and go back to the slide. Yeah, perfect.
So we did the USG and got the interpretations that the alpha angle of more than 60 degrees is either normal or physiological. And type 2 graph classification showed that the alpha angle should be between less than 50 degrees and the beta should be less than 77 degrees. And those hips are the most prominent ones for the Pollock harness treatment. The type D, type 3, and type 4 all should be attempted with the Pollock harness first, and then if the hips don't reduce, we have to move on to closed reduction or open reduction, depending on the types. Our hip, which was classified according to the alpha angle, which was less than 43 degrees and on for 38 degrees. So we started initially with the Pollock harness treatment.
So this was type 3, and we had a word with family that if the treatment fails, then we might have to go for further intervention. And let's see how it went.
The Pollock harness application was started, and the mother was encouraged to carry the child on the waistline on the side, which is a traditional Indian method of carrying children. And the patient was followed up after 1 week to check for femoral nerve palsy or irritable hip. After that, the sequential ultrasounds was done. After 2 weeks, the alpha angle came out to be 40 degrees and the beta angle was just still 78 degrees. And after 4 weeks, the alpha angle improved to 57 degrees and beta was 50 degrees. At 6 weeks, the alpha angle further improved and it came out to be 70 degrees and the beta was 45 degrees.
All right. So, Federico, what is your protocol of following these children once you apply the harness, and what you check on the follow-up examination?
So our protocol is to repeat as you did the ultrasound every 2 weeks, and we want to have 2 normal ultrasound in a row before stopping the treatment. So even once we see the first ultrasound that has become normal, then we repeat the ultrasound again 2 weeks later, so that we are sure that everything is okay and remains stable. And then, of course, our clinical examination looks for stability and symmetric abduction. But when you are into a public harness, of course, abduction, if the hip goes well, is going to be symmetric and quite significant.
So you will see the child on first week to see any signs of femoral nerve palsy or irritable hip and so on. What would you do that if a child develops, say, femoral nerve palsy, or a child is constantly crying with hardness on?
So if there is an issue with the positioning of the harness, of course, we will check it and be sure that the position is good, that is not too tight, that the hip is not too much into flexion and into a position that is harming the child anyhow. And then, of course, if everything is okay, we continue with the treatment. But if adjusting the public harness doesn't work, sometimes we discontinue the treatment for 1 week or so, and then we ask the family to come back and start it all over again. So we are not just applying the harness and then leave the patient and ask the patient to come back after sometimes. Especially at the beginning, we have a close follow-up. And then, of course, we adjust the follow-up according to the evolution. But usually, during the follow-up, we see the patient every 2 weeks with an ultrasound.
So, Jayant, are you here?
Yes, I'm here.
Yeah. So now, Federico rightly said that his end point is once he found the normal alpha angle, he will still continue the harness for 2 more weeks, and then he will discontinue. What is your protocol of discontinuing harness once alpha?
So I wait for 4 weeks from the point when the ultrasonographic parameters become
restores to normal.
Yeah, 4 weeks from the point where the ultrasound is normal. And it's a protocol I've been following for many years. There is no consensus really. Many surveys and things have been done amongst pediatric orthopedic surgeons, and there is no consensus. Are you going to talk about weaning?
So
at some point?
Yes. I mean, we can talk about it right now. Do you really wean from hardness, or you will kind of discontinue once the angles are restored, or keeping it for a couple of weeks and?
Again, there is no evidence. There is no evidence, and from all day, there was a paper about weaning, and weaning doesn't seem to show much difference. So there are people who, and also the brace time. So some people put the harness on for 6 weeks and then wean. Some people keep the harness on for 12 weeks and don't wean. So it's a very, very messy protocol if you look at the individual practices of all the big busy DDH units across the world. But each have their own kind of, it's almost like a recipe for DDH. It's not like an algorithmic approach. So I would encourage all the fellows to adopt a certain protocol that works well in their hands and just stick to it and not keep switching between protocols. I think all protocols work well. So long as you keep the child in harness for a period of time, say 2 to 4 weeks after the ultrasonographic parameters become normal, and the evidence is pointing towards no benefit from weaning. Once the hip is and ultrasonographically normal, I think the harness can be discarded.
So let me tell you my experience, we have been treating them, and once the alpha angle is normalized, in Indian scenario in Gujarat, the people tend to hold their babies in their waist. So I encourage that you carry the baby in the daytime in the in the brace, and of course they are putting diapers on in the night time. And some of them we ask them to do gently do the hip abduction exercises. And so our practice has been, we do not kind of wean patients from harness, and we have frankly not seen any residual dysplasia. Now the question from Dr. Gupta is, does the ultrasound protocol changes with graph grades? Say a child presented to you as a graph 4 or some child presented graph 2, would the protocol of getting follow-up ultrasound at 2 weeks would be the same, or it would change, Federico?
For us, it doesn't change. We always use the same protocol. And what is important is to make sure that the hip is getting better during treatment. I mean, that the hip is responding to treatment. We don't want to stuck with a non-effective treatment. So if the hip is not responding, then of course we may change approach. But if the hip is responding well, whatever the graph stage, we keep with the same protocol. We don't change the protocol according to the type of hip.
Perfect.
Of course, the amount of time in the public, of course, may change according to the severity of the hip. And maybe longer,
do the
of course,
follow-up
the more severe
ultrasound?
the hip.
Yeah. Jayant, do you do the ultrasound with harness on or off? I think we get the harness off and we do it, right? Jayant? Is how once the hip got located, Federico, how long you will follow this child? Would you follow them for long, or at 1 year you will graduate them from your clinic?
If you have a confirmed, I mean, dysplastic hip, we follow the patient up to age 15 at the end. But of course, the frequency of the follow-up may change. But at the very, let's say, beginning, the follow-up is very strict. So we see the patient then at 6 months, then a walking age, 2 years, 3 years, and then according to the shape of the hip on X-rays, we may continue with the year follow-up or spread the appointments apart. Let's say if the hip at 3 years is normalized, then we see the patient at 5, 10, and 15, and then we stop a follow-up. On the other hand, if the hip is still sorry?
Right. So even the hip, which has been reduced well with a harness, you tend to follow them till 15 years, right? That till the skeletal maturity.
Yes.
Okay. Jayant, is the same. You do the same thing. I have been doing this for the open reductions, but do you think we should follow all these hips till 15?
Absolutely. So I take a lot of time to counsel the parents that the hip, that the end point from my point of view is at skeletal maturity at 16 years of age. And I tell them, even if they move out of Bangalore, and many of my patients do, I tell them, please see a pediatric orthopedic surgeon at 16 years of age to make sure the child has a normal X-ray. And if at any point, particularly during teenage years, if they develop pain, definitely seek advice.
Perfect. Yeah, Kunal, let's move ahead and see what has happened with this girl.
On 10 months, sir, we did the X-rays to confirm that the femoral epiphysis is visible.
So as Federico pointed out earlier, that capital femoral epiphysis is late to appear, but once it is well centered, we see this femoral epiphysis start appearing. And this child was doing well till 3 years, so we didn't follow her up. But recently she came, so she is representing Gujarat in Taekwondo at national level, and she had some wrist sprain. So she came to see me just before a few days, and she is in the center, and we got this opportunity to take her hip x-rays. But fortunately, this x-ray looks okay, Federico?
Yes, X-rays are normal to me.
Yeah, and she's well grown. So, but I'll take it from now that we should ask them to follow till the skeletal maturity, and this ended up into good outcome. Let's move on to the next case now. Yeah, Kunal, please provide your information. So Kunal, last slide is important. Can you run us through? Yeah, please.
The predictors of polyc harness success are shown in this paper, which was published in JCO 2018. The positive predictors are treatment should begin before 7 weeks, and the graph classification should be class 2 or less. And the parents' compliance is most important for the patient's outcome. The negative predictors for polyc harness are graph 3 or 4 because they are highly dislocated. The hips, the acetabular index of more than 36 degrees, complete dislocations, and bilateral involvement and ligament laxity are the negative predictors for polyc harness success.
So Federico and Jan, quickly tell us that how much time the patient should spend in harness for a successful outcome, you know.
Somewhere between 6 and 12 weeks.
No.
Minimum
In a day, you know, if you have started
Oh.
treatment, 2 weeks have elapsed. Now family says we want to keep it off for a few hours a day.
Not allowed.
Not
Minimum
allowed.
23 hours a day.
Yeah. And Federico, what is your?
Yeah, the same. Same. I mean, if the patient requires a public harness treatment, if I understand well the question, the treatment is full-time, it's not part-time, or because things are getting better, we decrease the amount of hours. I mean, from the beginning till the end, it's a full-time treatment.
Perfect. So this is not that they can take it off for a few hours. It's not like a Ponseti thing. It has to be full-time. Yeah.
In Europe, some centers do like this, especially once you have got the first ultrasound that is normal, then the patient are allowed to take a bath. I mean, to have the child take a bath, so to remove the harness and put it back. But in our practice, we don't allow to do so. So for us, the treatment is full time from the beginning till the end with no interruption.
What I do is after 2 weeks, once the family is well versed about how to apply the harness, we ask them they can take baths and then put it back in, but they are not allowed to do it for a pretty long time. Okay, let's move on. Kunal, next case, please. Vaibhav.
Yeah, very good morning, everyone. So I'll talk about the second case. This 2 days old female was referred to us by the obstetrician in view of bilateral foot deformity. She thought it to be clubfoot, and on history, we found out she was a full-term baby born by C-section with a horizontal lie. She was the first-born child, and we found out that the child had postural metatarsus adductus. Child was examined for other signs of intrauterine crowding. So clinically, there was unequal abductor spread, which was terminally limited on right side. Rest bilateral hip range of motions were normal. Sacral dimple was present, and there was no evidence of torticollis.
So for all the fellows, what are the signs of intrauterine crowding? When Vaibhav, what do you mean by that? Which are the 3 signs we check for intrauterine crowding, you know?
Basically, sir, we screen the hip for DDH, and we screen the feet for clubfoot or any other deformity of the foot, metatarsus adductus. And again, torticollis is a very important sign we check for, which is the next.
So for all the fellows, you know, when you see a unilateral metatarsus adductus, there's a sign of intrauterine crowding, and then you should check the hips and have a very high suspicion of DDH, and also look at the neck, because this is a triad of intrauterine crowding, and you might get surprised to see that's what happened in this case. Yeah, go ahead.
So we got a sonography done on the second day itself, and it revealed bilateral dysplasia alpha angle on the left side was 49 degree and it was more on the right side. The dysplasia was more on the right side. The alpha angle was 42 degree.
So Jayant, like on the second day of life, alpha angle is 42. Would you be serious about it, or would you observe this, and why? What do you think?
So second day of life, but there are also other risk factors present.
Yes.
I'll check for clinical instability. If the hips are clinically stable, as in Barlow test is negative, this is a hip that is in joint. So I would do the
Yes.
Barlow test. And if the Barlow test is negative, as this is a clinically stable hip, I would probably wait 2 weeks.
Right.
I wouldn't go in a clinically stable hip. If the ultrasound parameters are a little bit low, I wouldn't be in a hurry to start harness treatment. I would, serially follow it up at 2 weeks and 4 weeks. And if the ultrasound parameters are improving, I might just wait. This hip might
So
improve by itself.
why
It's
we
just
see some hips are immature at this stage?
because
Would you
it's
like to tell?
physiological immaturity. Physiological immaturity is extremely common
Right.
in babies. So I would treat only clinically unstable hips at birth.
Correct.
A physiological immaturity waits until about a month or so before I start harness treatment.
Right. So let's see, Vaibhav. We plant the same, Jan, that due to maternal relaxin hormone, these children have immature hips and they would settle down by themselves. So at 2 weeks, we call them, yeah. And at 2 weeks, the alpha angles are same, and the hip is just remain at 2 weeks, Vaibhav. Don't reveal. Anyways, so Federico, now what I also see is the coverage of hip. It's more than 50% of hip is out. Alpha angles are in 45s. Would you do anything at this point, or you would wait?
So our approach is like this. If you have a child with the risk factors and normal clinical examination, then we postpone the ultrasound after 4 weeks of age because of the false positive risk, which is too high in very young babies.
Right.
On the other hand, whatever are the risk factors, if the clinical examination is abnormal, then we do the ultrasound right away.
Perfect.
So in this case, if the child has risk factors, but clinical examination is normal, so hips are stable, then we do the ultrasound, but we would have done at age 4 to 6 weeks.
4 to 6 weeks. Okay. So the same philosophy. A child less than 6 weeks present with risk factor with normal clinical examination, you don't indulge into treatment or ultrasound, because once the ultrasound angles will be bound to be low, and then parents will get panicky that it's not 60 and you do something. But in those patients with the normal clinical examination, you do ultrasound at 4 weeks or 6 weeks. And then if it is persistently dysplastic, you start the treatment. Here, it was referred by a doctor with a very strong suspicion of DDH. And so, I mean, the feet and the family. So we got this, but now we follow the patient at 4 weeks. We did not start the treatment yet. Yeah, Weber.
So again, the dysplasia persisted at 4 weeks. As we can see, the alpha angle persisted at 46 degree and 45 degree respectively on the left and the right side.
So Jan, should we start harness now?
Yeah, I think so.
Yeah.
This is a kind of tricky case. Like Federico said, I wouldn't, in a clinically stable hip, I would probably wait until 4 to 6 weeks for the first ultrasound scan, and not scare myself or the patients into starting treatment early. So, Yeah, but now it's like a 50-50. I would leave it to the parents. I tell them, if you can hold your nerve for another 2 weeks, let's do another ultrasound at 6 weeks and see. But if the parents are a little edgy and nervous, I'd probably put the child in a harness.
So the same scenario was here. Parents were kind of very hesitant to wait further, and Vaibhav, show what we started to do.
So we started with harness treatment at 4 weeks in view of persistent dysplasia. And we followed up with sequential sonography. So we followed it up at 8 weeks and 10 weeks. And again, at 8 weeks, there was no improvement on the alpha angle. But at 10 weeks, it improved to up to 50. So it became graph 2A.
So now, no, it's not a very quick resolution of alpha angle as we see. The child is 2.5 months, and alpha angle is 50, but of course there's marginal improvement. But still, so how long you continue the harness treatment, Federico, before you think that harness treatment is not successful?
Is a little bit the same approach as for harness discontinuation. I mean, if the hip is not responding after 2 or 3 ultrasound, then you discontinue the treatment, because otherwise you may increase the risk of complication of harness treatment. So for us, let's say in a good or bad way, is the answer is the how the hip respond to the treatment, whether you stop or you continue. But once the hip is not responding anymore, then we stop the treatment. We don't start with the treatment with the hip that is not responding to it.
So hip not responding means you mean that alpha angle is not changing, right?
Like in this case, it looks that after 10 weeks, you still have some abnormalities in the hip. So probably this hip, after, let's say, 1.5 months of treatment, is not responding well, or at least is not responding as much as you would expect to the treatment. So then you have to consider stopping the treatment.
Okay, Jayant, would you stop treatment at this point? Child has spent 6 weeks in harness, and still alpha angle is not good.
I would.
Or you would continue.
Yeah, I would. I have many such patients. So I just stick with the treatment, because then I think, okay, if I have to stop the harness, what do I have to do? I have to do an EUA, an arthrogram, and I'll have to put a hip spiker. And what is a hip spiker going to do? I'm going to keep the hip spiker on for 3 months, and if the parents are compliant and they're applying the harness correctly, it is the same position in the harness as the hip spiker. So harness is more convenient, always.
So clinically, what I found, this child has a bit of hyperlaxity in this case.
Yeah.
And I have seen that if child is a bit on lax side, they take longer time to respond to harness treatment. And that was the case with this. So Vaibhav, can we see the next slide? So what? Yeah. So we switched to a rigid hip abduction orthosis at this point, because in this child was kicking a lot, and I think do you consider, Federico, anytime a rigid brace instead of harness when the child doesn't respond before jumping onto any other treatment of surgical treatment, I mean?
We tend not to consider rigid braces until the child is a little bit older, but we may switch to a different abduction brace, like the tubing and splint, if the child is not really responding to the public harness. So the principle of the tubing and splint is the same as the harness, but it's just a little bit more rigid. So it keeps the hips into abduction, maybe a little bit better than the public harness, especially in bigger child. But of course, if the child then is older than 5 to 6 months, then we switch to a real rigid brace if needed. But up to age 6 months, we try to continue with the public harness. Our cutoff for switching is around 5 to 6 months of age.
And not the amount of time the child spent in harness.
But because of for us, as I said before, it's a full-time treatment, so we don't have any difference in amount of time in the harness, whether the child is 1 month, 2 months, 3 months, or 4 months of age. So we are not adapting the treatment to the age of the patient or to the severity of the hip, as I said. It's just the same
we
type
need
of
to
treatment
continue
for
the
all
harness.
patients.
Perfect. So let's move on to, in this case, Vaibhav.
So again, we repeated the ultrasounds after 1 month. At 3.5 month of age, alpha angle improved up to 55 degree. And at 5.5 month on our last follow-up, it was 63 degrees. So it appears to be normal now.
Yeah. Go ahead.
So reviewing this is the last follow-up clinical image. As you can see, the child is harness-free now, and the hip range of motions were normal.
Yeah. So we asked them to continue the solid brace for 1 month, even after correction of the alpha angle. And the messages, as Jan said, that some of these patients may take a little longer time after harness treatment, and 6 to 8 weeks is a time where you can abandon harness treatment if the alpha angle is not improving. But if it improves, then you can still continue for some period of time. Yeah, Vaibhav, quickly go through the literature. Yeah.
So prolonged harness treatment, similar experiences were there in the study done in Netherlands, published in JBJS. They studied 62 hips, out of which only 21.6% reduced at first 6 weeks, and up to 75.7% reduced at 18 weeks. Their mean total period of bracing was 13.4 weeks.
Yeah.
Again, another study, they found out that 45% patients who failed Pavlik harness treatment successfully responded to rigid abduction bracing and concluded no negative changes on alpha angle on prolonged harness treatment. And again, no compromise in subsequent treatment.
Fine. Let's move on to the third case. Yeah.
The third case is of a female child, 6 months old. She presented with the unequal limb lengths, and she was the firstborn female child and born by vertex presentation vaginally. On clinical examination, the abductor spread of the left hip was limited. Galeazzi sign was positive, telescopy test was positive, and ortolani was negative. The X-rays at presentation showed this, and
so now, Jayant, as you say that classification of IHDI. So Federico, what classification you use? Is IHDI or the Tonis? Of course, this hip looks fairly dislocated. How would you interpret this X-ray?
So we use, before we use the Tonis, now we use the HDI classification. But actually the two classifications are based on the same principle, that the hip dislocates progressively from the original position laterally and then upward. So in this case, we see a left hip dislocation. Shenton's arc is interrupted. There is acetabular dysplasia. The socket is swallowed. There is no Cephalic nucleus. So yes, this is probably let's say a Tonis grade 3, or yes, the corresponding grade of the HDI classification.
Right. So yeah, Kunal, show what is IHDI and how this hip was classified.
We studied the IHDI classification, which was published in JPOB in August 2015. According to this classification, we have to mark the center points and draw the Hilden-Regan line and then the Perkins line and the 45 degrees angle line, which will tell us that the hip on the left side is dysplastic and the right side is normal.
So, Jayant, based on IHDI, would this change your management or prognostication or discussion with the family?
Yes, it will, because this is like an IHDI 3, almost 4.
Yeah.
So I would, depending on the age of child at presentation, I think I would make some comment that this is a higher IHDI grade, therefore it's a more severe dysplasia, and therefore less likely to respond to conservative treatments and a greater chance that we may have to, do a closed reduction or a hip spica, etc. So I just use it as a rough guide to counsel the family,
Yeah.
and also for my own understanding of how severe the dysplasia is, because as we know, DDH, there is a genetic factor underlying.
Yeah.
So it helps you to judge what you may have to do in the future.
Would you try harness at this age? A child is 6 months old.
Yeah,
no?
you can. But I think a rigid hip abduction orthosis, if the hip is relocating well and there
Yeah.
is good abduction, I think you can try conservative treatment. But at 6 months, I think you are
Yeah, it
more.
will not
I am
work.
more likely to go for a EUA arthrogram, because at 6 months, if they are presenting, then there are more likely to be something inside the joint, lax capsule, etc. So I would be edging towards taking the child to the OT, doing an arthrogram, and being absolutely convinced that the hip is okay, because we have lost 6 months of good time to get this hip better, and we are, you're racing against time always with DDH,
Right.
and the age of the child at presentation is a very important factor. So you don't have much time to waste now, so you have to act immediately.
Yeah, Kunal, we thought the same way. Kunal, can you move ahead and show what we did?
We did the adductor tenotomy and a closed reduction, and the arthrogram was done to confirm the position of the head intraoperatively, and the spica cast was light.
So under anesthesia also it was not reducing well, and hip adductor long is very tight, and so tenotomy was done, and as it was done, it jumped in. And it's your routine practice, Federico, to do arthrogram for this kind of hips, yeah?
Yes, the same approach. So we do arthrogram, adductor tenotomy, and then usually with the adductor tenotomy, you increase the abduction and those hips reduce well. So really is the adductor that hinders the reduction. So we do it very frequently. And then of course, spica cast. And we apply a spica cast for 3 weeks. We change the spica cast for 3 months, sorry, so 12 weeks. We exchange the spica cast after 6 weeks in all patients under general anesthesia. We do this changing. And then after 12 weeks of spica cast, we apply a splint, an abduction splint with the flexion extension of the hips that is free. And then, of course, we continue follow-up of the patient.
Right. Do you do any post-operative MRI or CT scan? Because on post-operative X-ray, you won't be able to see the capital femoral epiphysis yet, no?
So the gold standard to check reduction is MRI. MRI, we try to have it the same day of the closed reduction because of the anesthesia the patient already had for the closed reduction. Then we send the patient to MRI scan after
Just
the
a minute,
reduction.
Federico.
Yes.
If we log out again, we will log in again, okay? Sorry for this. Yeah, please carry on.
So we send the patient to MRI the same day, but for some reason, if it's not possible, we do the following day. But because the patient is in a spica cast, you may not require a general anesthesia because the patient is not moving, so you can do it in a sort of an awake position. We ask the families to feed the patient before the MRI, and then the patient is sent to MRI.
That's right. So yeah, Kunal, that's the same we did. The patient had located So Kunal, please share your, yeah, perfect. Go ahead. I'm sorry for this thing.
So the pre-treatment acetabular index was measured from the left and the right side. The right side acetabular index was 24 degrees and the left side was 40 degrees at the pre-treatment part. And after 1 year of the treatment, we did the X-rays and found out that the acetabular index was left side was 26 degrees and the right side was 20 degrees. We also
so what is important is we do an arthrogram and make sure that its hip is very well reduced, and if we find that there is more medial dipole or it's not a deep reduction, then we will go ahead and do the open reduction. And this is a nice algorithm that David Skaggs and people have published, and we follow the same. So let's move on to the next. And the practice, hip spica, we keep it for 2 months. We spend a lot of time explaining the families about how to take good care within the spica. We have also developed a spica stroller at our place, and we can keep it continue for 2 months. And most of the patients can keep the spica clean. And as Federico suggested, after 2 months, we remove the spica and switch them to the rigid hip abduction orthosis. And for 15 days, it's a full time, and 15 days night time. At 3 months, we graduate them from any splinting, and then we follow. The question is from Sudhanshu, minimum age of open reduction in your practice. So Sudhanshu, I think this is if the child is not stable after closed reduction, then you have to move on, because you have to bring the hip in by all the costs. Yes, Federico, you think the same way? We have to make the hip stable at the end of the procedure, right?
Yes, I mean, the reduction must be concentric and the hip must be stable. And of course, you have to have a stable hip without forcing it too much, meaning you don't have to have too much of abduction to keep the hip in. But of course, here, this is source of debate. Usually, you should have the hip in what is called the safe zone of Ramsey, meaning that you don't have too much abduction to keep the hip in, and you don't have not enough abduction so that the hip redislocates. But you have to find a balance, but of course, the hip at the end of the procedure must be stable.
Yes. So question
reduction must be not forceful. Exactly. Let's say this is the term.
So Vigneshwaran is asking, if hip is not reducible at 6 months by closed reduction, when to proceed for open reduction? So all of us practice that. We tell the family that there is high chance that we will be able to reduce by after doing adductor tenotomy. But if it does not reduce, then we may go on for either a medial open reduction or anterolateral open reduction, whatever method you are happy with. But as Federico said, that it has to be a gentle reduction and not very forceful reduction. Yes, let's move on to the fourth interesting case.
Yeah, so this 7 days old female presented to us with right leg flexed from hip since birth. She was born with C-section due to breech presentation at term, and attempt at extending the hip was associated with excessive crying. There was no history of neonatal ICU admission or antenatal maternal infection.
So Jayant, have you observed this phenomenon? Sometimes a breech baby keeping one limb completely flexed at 90 degrees. And that was something alarming for the family. That child is not extending the hip at all. And it was crying relentlessly when they attempt to extend.
No, I mean, I've seen the CDKs, the congenital hyperextension of the knee, but excessive flexion, I mean, I would suspect a birth fracture or something like that.
Yeah.
But not with DDH.
Yeah. So yeah, the X-ray was okay. I was worried that there is septic arthritis going on, but patient didn't have any history of NICU admission. Neither the mother had, antenatal infection history, and the blood markers were also negative. So this was an, abnormal presentation to us. The child was keeping one limb flexed. We see that they are like this in the bridge. They are hyperabducted, and they sometimes show on inferior kind of obturated dislocation, but this was a bit odd presentation. Yeah, let's move ahead, Vaibhav.
So clinically, we found out restricted abduction spread on the right side. The hip had fixed flexion deformity of 45 degree on the right side, but we were not able to elicit Ortolani or Barlow maneuver in this case. A blood investigation, TLC were normal, CRP was normal, and sonography screening of the hip was done, but it showed no collection, but the hip was found to be dislocated.
Yeah. Can you move ahead in the imaging? Yeah.
So we got an X-ray done, and this was the X-ray done at 7 days of life of age, and we found out dysplasia on the right side.
So, Federico, how would you read this X-ray? We got an X-ray to see any fracture, as Jan pointed out. What do you think this is? How would you read this X-ray?
So, of course, the hip is dislocated on the right side. Maybe this is a teratologic hip dislocation. So we have to make be sure that it's not a teratologic hip dislocation. Because if this is the case, then the approach may be different compared to what we have just said up to now.
So what will define
because
that
it's rigid and the hip is stuck in flexion, this is a bad sign, I would say.
Yeah. So Jayant, how would we differentiate that this is a teratologic dislocation and not a develop? Of course, this is just 7 days and this X-ray, so it has to be an antenatal dislocation.
An antenatal dislocation, a dislocated hip at birth is a teratologic dislocation, which means it never formed properly. DDH is a hip that initially may have formed properly, but subsequently became abnormal over time. So this is clearly a teratologic hip, and
and Sudhanshu rightly said that there is a formation of pseudoacetabulum, which is again a sign that it was antenatally dislocated. Yeah, I agree with you, Sudhanshu. Yeah, Jayant, go ahead, please.
So these hips obviously don't behave well. But I would try and see if I can gently put these hips in a Pavlik harness. Some of them may improve, most of them will not. And the family has to be counseled accordingly.
Okay. So, Federico, can you tell us your approach of so-called teratologic hip dislocations? How would you approach them?
So those hips, as it is just been said, we can try initially with the public harness, but if the hip is not responding to treatment, we discontinue the treatment very quickly. So we tend to leave the hip alone for a while, and then in our approach is to leave the patient, leave the hip alone, and then to go back when the patient reach the walking age and do an open reduction.
Okay. Jayant, would you wait till walking age, or you will intervene early?
So my earliest cutoff for teratologic hips is 6 months, because there is some evidence that if you give GA in children under 6 months, there is some long-term neurodevelopmental issues and things like that. So I wait 6 months, and then when the baby crosses 6 months, I would do an EUA, arthrogram, and most likely a medial open reduction, because I do medial open reductions. So at 6 months, and I have a large series of teratologic dislocations, maybe 30, 40 hips that I've done medial open reduction on, and my results have been, reasonably successful. I'd say more than 80% success rate without AVN and other problems. So at 6 months, I would do a medial open reduction, which in my hands is successful in teratologic hips.
Have it happened any time that they are so tight that even after medial approach, they have not reduced, or you need to pull them too much to bring them
Not
in?
at 6 months. Not at 6 months. Because in the older hips, at 9 to 12 months in teratologic hips, when they are presented to me at that age, I have had tight reductions, but not at 6 months. Even the teratologic hips at 6 months will go in very easily with a medial open reduction.
Okay. Yeah, Vaibhav, let's move ahead and show what has happened.
So we advise the parents to do gentle stretching exercises for another couple of weeks, and then after the resolution of fixed flexion deformity, we initiated the patient on Pavlik harness. We followed up with serial ultrasonographies, but the harness was discontinued as there was no improvement even after 6 weeks of application of the harness.
So typically on ultrasound, the hip is behind. So the ilial line and the femoral head are in the different planes. So you cannot see the hip in the same plane as we see in the routine DDHs. So as we pointed, it was not responding to harness. So we discontinued, and what we did, as Jayant said, we went in at 6 months and tried close reduction first. Yeah, can you show the image, Vaibhav? So we did an arthrogram also, and I was not very happy with the reduction. And you can see there's more than 5 millimeter dipole with very shallow reduction. Jayant, what would you do?
Just do a medial approach. This is a very easy hip to do with a medial open. I actually call it like an assisted closed reduction, because you can do it with like a 2 centimeter incision, which you're going to make anyway for the adductor tenotomy.
Right.
So just extend the adductor tenotomy by another centimeter, and I use the modified Ferguson approach. You directly drop into the hip. Just need to be careful about the circumflex artery, and then you can address all the components of the dislocation. It takes 15 minutes to do. It's a very simple and easy operation, and I would encourage all the fellows to learn it.
Yeah. So most important, we will discuss medial open in subsequent case. But somehow at this point, I do not remember. This was, I think, I did this case in 2010, before 15 years. Of course, I had assisted Dr. Cole in a lot of medial open reduction at OrthoKids. Federico, we did assist him. But I went on doing anterolateral open reduction. Yeah, and Vaibhav, can you show?
Yeah, so we went in and did an anterolateral open reduction, and we applied hip spica for 2 months subsequently, which was followed by a hip abduction orthosis for 1 month.
So the message is, if the fellows, it's very good approach to learn medial open reduction, but if you are not well versed, So there is no harm in doing anterolateral open reduction also. Okay. But if once you learn the medial open reduction, you will find it more easier. And at some point, in very rigid teratologic higher adding DDHs, even medial approach is insufficient. Recently I had a case. We did medial approach, Jayant, and somehow we were not able. I could see the head, but it was not coming down. And in one of the cases, we'll show you. So yeah, so in 2010 was my practice. Yeah, let's go through this case.
So we followed up at 2 years of age, and the hip was well reduced, but still there was some persistent dysplasia at the right side with articular index.
So let's know from Federico, what is the protocol of following patients after open reduction? Federico.
So this patient we follow now once a year, the patient that you have just treated. So
okay.
Now this patient undergo a yearly follow-up, and then we see how develops the acetabulum. Usually the acetabular index tends to improve up to age 6-7 years. So we monitor them, but we want to be sure that this acetabular index is improving as well. And then we just want to rule out residual acetabular dysplasia during follow-up. So let's say we follow the patient once a year. If the hips are normal, then we spread the appointments apart. If the hips doesn't normalize, then we will act accordingly.
So a child at 5 years with a full range of hip motion, but acetabular index is say 30 degrees. Of course, sentence arc is okay. Would you do an acetabular procedure at 5 years, or you would wait further? Range of motion is full, but acetabular index is not improving.
So it depends on how the acetabular index was before 5 years of age. I mean, if you started from, let's say, 38 degrees or 40 degrees, and now you are in a positive trend that things are improving, you are not requiring an immediate treatment because you still have maybe a couple of more years of improvement. However, if you are with an acetabular index that is not improving after 2, 3, or 4 years of follow-up, then in this case, yes, you may need an acetabular procedure to correct the residual acetabular dysplasia.
So it's not the number of acetabular index, but a sequential, the degrees, which if it is improving. And more important, I remember Dr. John Wedge, if Shenton's arc is intact, many a times, you are fine. But there were later papers that Shenton's arc is not a very reliable radiologic sign either. Yeah. Jayant, is there the same approach you follow for secondary procedure?
Absolutely. So trend over time is the most important variable that I use. And sometimes it will improve and then it will plateau. And if it plateaus at a high angle for like a year, 18 months, 2 years, then I would again be inclined to do something.
Perfect. So this, we tend to follow them annually, as Dr. Federico said, and this child came recently for 15 years follow-up, 12 years follow-up. Federico, can you have a closer look at this X-ray? And Jayant, you too. The girl has full range of motion. She is a young adult. But why there is so much of sclerosis in acetabulum on right side? Is this normal, or actually that's there on both the sides? It's some metabolic bone issue, or?
I don't think so. I just think this was a teratologic hip to start with.
Yeah.
So there is something genetically and anatomically abnormal with this hip.
Right.
So, I mean, we have managed to get a good result by doing the right procedures at the right time. But these are not normal hips, in my opinion. There is something wrong with the whole hip itself.
Right.
But it looks, I mean, all the radiographic parameters are good. Child has a good range of movement, symptom-free. So I would discharge them from follow-up. saying,
Yeah.
if in case you get any hip pain, go and meet an adult hip surgeon at some point.
Right. Federico, you think the same? There's the okay X-ray?
Yeah, the result is good. So she's already 12. Maybe I would ask this child to come back around age 15 or 16 when she's skeletally mature. Because as I said before, hips that normalize, we see them at age 5, 10, and 15 years of age.
Yeah.
But just to warn the family about hip pain, so they may require an earlier appointment if the child develop pain. But otherwise, the X-ray outcome is very good.
Perfect. Let's move on to 2 cases very quickly. Yeah, so there's longer term follow-up, and let's move on. We'll post these papers in our fellows group. Okay, Vaibhav?
Yeah.
Yeah, Kunal.
This is the 5th case. Now we have 2 months old male child with the left-sided CVT and bilateral hip dysplasia with bilateral thumb and palm deformity. He was diagnosed as Arthrogryposis multiplex congenita. This is the ultrasound images at the age of 2 months, and the X-rays images showing that left foot had congenital vertical talus.
So, Jayant, how would you approach these patients with foot deformity and hip dysplasia, arthrogrypotics? As you can see, they are already dislocated on ultrasound.
So I would leave the hips alone. I
Yeah.
wouldn't focus on the hips at all. I
Perfect.
get the CVT corrected
Correct.
first.
Yeah.
Reverse Ponseti, and if necessary, I would do the minimally invasive approach to do a TA tenotomy and pin the talonavicular joint, do some splinting for the feet, and get ready for DDH surgery between 6 and 8 months of age.
Perfect. So go ahead, Kunal, and we did the same, reverse Ponseti.
The treatment advice was like that only. As sir explained, reverse Ponseti casting was started and followed by open reduction K-wire fixation at 3 months of age, which was completely corrected by 6 months. We returned back to the hip after 6 months with an ultrasound, and the ultrasound findings showed.
Yeah. Can you move on to X-ray?
At 10 months of age, the X-rays was done, and he was advised for medial open reduction.
Yeah, so we were like, child had we advised bilateral medial open reduction 6 months. Child had some respiratory infections and so on, but by 10 months patient was ready. So Jan, do you think these are the good with your medial approach? Can we put it back in at 10 months?
Yeah, these are difficult hips to do. I would not advise someone who doesn't have experience in medial open reduction to do arthrogrypotic hips. So you should do at least 10 medial open reductions in regular DDH before you start doing arthrogrypotics. The arthrogrypotics are very, very difficult because the muscle planes are not properly developed. There is a lot of amyoplasia around the hip, so you can easily lose your way. So these are difficult hips to do. But I'm able to do it only because of experience. That's all. I've done a lot of these.
But
this is not
I
would expect problems in an arthrogrypotic hip with medial open reduction. They are never straightforward.
Another I remember Dr. Cole saying that adductor longus is sometimes fibrotic, which is very important anatomic landmark. And so doing a medial open reduction in this hips is sometimes very difficult. Federico, how would you approach this hips now at 10 months?
We will do an open reduction, but we do open reduction through an anterolateral approach. But the idea is the same. Now you have to, once you have solved, you have managed the feet, then you make sure the knees also are good, at least good, because this is an issue in arthrogryposis. And then, of course, you take care of the hips. You go from the bottom to the top.
Now, would you do in 2 stages, or you would do bilaterally on single stage?
we usually do one hip at a time. So what we do in those cases, we do the first case, then we put the patient in a cast, but after 6 weeks, we do the second side, and then we start with the 12 weeks of spica casting. So the most severe hips stay in cast 18 weeks, whereas the one that we perceive as more, let's say, manageable, goes into the spica cast only 12 weeks because undergoes a surgery in second position.
Right. Jayant, how would you approach it if you do medial open reduction? You do both at the same sitting or at the interval of some period?
No, because I do medial open, I can do them bilateral simultaneous. But if I'm doing an anterolateral open reduction in an older child, say more than 12, 14 months of age, I would probably do it sequentially, one at a time.
And after a period of how many months?
I generally stagger them by about somewhere between 4 to 6 weeks. So I'm reducing the total time in spica. But I want the first hip to stabilize reasonably well before I attempt the other hip.
You know what I have observed, this is on my own observation, is the patients, earlier I used to span them at 4 to 6 months time. I would let the spica off on one side, let the child move around, let him be free, and then you operate on the other side. And those patients were doing quite well. And then I started doing that. The patient spends 3 weeks in spica. I would remove the spica, put a temporary wire on the opposite side. Then I operate the other side, remove the wire, apply spica. And I found that these hips, when they spend longer time in spica, they are very stiff. It takes very long time for rehab. Some of them, they have sustained fracture, even though you give vitamin D and calcium. So, Federico, what is your experience? I find that if I do in stages at the interval of 6 months, they do better. Of course, we don't have any comparative study. What is your long-term experience?
Of course, the hip are stiff when you remove the spica cast, especially if you have been doing the cast for 18 weeks overall, at least for one hip. But really for us is important that once you reduce the hip, you keep it immobilized in a spica cast so that the capsule can shrink and become stiff and keep the hip in place. And then to gain motion back, this patient have time, let's say. So for us, it's important that the hip, once you do this open reduction in those difficult hips, the hips remains located. So this is our primary goal.
Right. So let's see what happened. Jayant, I'll show you what I've done. Kunal, go ahead.
So the post-op X-rays was these, and the post-op immediate.
So I think I did the same bilateral medial open reduction in a single sitting, and that has been our practice also, Jayant, now. And after that, Ian Tarot's paper, we have been doing this ligamentum teres plication on the medial capsule. Do you do the same, Jayant? Ligamentum teres plication. Jayant, are you there? Or so yeah,
Sorry, I'm here. No, I don't believe in the stenodesis. I don't feel it adds anything at all.
Okay.
I do it, but I don't, even after stitching it, I can still pull the hip out.
Yeah, so I had it has happened once with me. I did the plication and the hip went out after medial open reduction. So I'm not sure. But in this child, we did, and yes, Kunal, show us the follow-ups, 3 years and 5 years. So this child is now 4.5, and the hip on the left side. Oh, this is 5-year follow-up. Okay. So Federico, on the left side, there is some dysplasia, but can you go back one slide, Kunal? Yeah. So looking at this, dysplasia which is improving, even though child is at 5 years of age with high acetabular index, we would wait. There's a message for fellows. And if the child has full range of motion, and for me, I see Shenton's arc is intact, then we would follow this hip. Yeah, show the last 5-year follow-up. Now, interesting fact about this family is the father had the same pathology, bilateral hip dislocation, vertical talus, and bilateral thumb in palm. And before 35 years, the system of diagnosing things were not that so prompt. Patient was in a remote place of Gujarat, so they got it operated at the age of 3.5 years with Dr. Professor K.T. Dholakia in Bombay Hospital. And you'll see 32 years of follow-up of that person, the father. And I happened to treat the younger sister, which also had the same pathology, bilateral hip dislocation, bilateral CVT, and the thumb in palm. So, Kunal, can you quickly take us through that X-rays of that father?
Yes, sir. The family,
go ahead. Yeah, go ahead. So this was Bombay Hospital.
Yeah, the pre-operative X-rays showed complete dislocations. He was operated at 3 years of age in 1996. Then 1 year follow-up was conducted after the there was a dysplasia at the hip, and the joints were reduced completely.
Can you run through the X-rays, Kunal? Yeah. So when he brought a second baby, I asked him to get his X-rays done. And Federico, so this hip did good for 32 years, operated at 3.5 years. Jayant?
I'd be very proud of myself if I could produce these X-rays.
Yeah, so this was Dr. K.T. Dholakia's surgery after 32 years. And then the father had both the children having bilateral DDH, and we did bilateral medial open reduction. So we'll see if I'm alive that what happens at this children, and we have comparative thing. So the learning point was that even if a child presents to you at 3.5 years, arthrogrypotic, still you can get good outcome with a good anterolateral open reduction. So let's post this paper in the fellows group, and let's move quickly through the last case.
So coming to the last case, we are talking about an 8-month-old boy. Parents noticed left lower limb shortening. He was a full-term C-section breech presentation baby. No history of postnatal hospitalization. So on clinical examination, we observed a deeper crease on the left side. The Galeazzi sign was positive. As we can see, there is femoral shortening on the left side, and the telescopy was also positive on the left side. Abduction spread was restricted on left side. Yeah. So X-rays at presentation, we got an X-ray done, 8-month-old boy, and we can see a high riding femur on the left side with dysplasia. We graded according to ISDA and TONUS, and both were grade 4.
So Federico, this is, as you say, the capital femoral epiphysis is not visible. And would you, this patient is from a remote place. There is some dysplasia. Would you do an MRI to see what's happening with the head, or you will go ahead for intervention?
No, this patient will undergo MRI. And then according to what we see on the MRI, then we decide how to treat. Because so if I remember well, he's already 8 months of age, this patient.
Yeah.
Yes. We can do an ultrasound, but for planning the treatment in this older child, probably the MRI is a better
How MRI would
option.
help you? Just to rule out that the head shape is okay, how would the MRI will help you?
Just to see the shape of the femoral head, and then to see if what's going on around the joint, because of course probably there is the labrum that is interposed. Then the MRI would be very helpful to study the shape of the acetabulum, because in those cases in some of these cases you have a sort of an hypertrophy of the 3-radiate cartilage. So you may see on the MRI that instead of being concave, the acetabulum is somehow convex. So you may not have a real hole where to put back the hip. So it's better to know it in advance.
Okay. Let's see what happened with Vaibhav.
Yeah. So we planned surgical intervention in view of a stiff hip, 8-month-old. We did an adductor anatomy, but still there was no mobility in the hip. So we did an anterolateral open reduction, removed all the obstacles in reduction, did all the standard releases. Still, the reduction was difficult.
So, Jayant, this has happened for the first time in an 8-month-old baby. I was not able to reduce after standard anterolateral open reduction. Have you ever experienced that?
Not at 8 months. I have experienced it just after 12 months in a 14-month-old baby, I think. It's the
Federico?
youngest femoral shortening I've done.
Federico, what is the youngest femoral shortening in your series? You are mute, I think. Federico, you are mute. Yeah. What is the youngest child?
Just below 1 year of age, between 9 and 12 months, I was saying. But those hips, usually we try to put them in traction before doing the reduction. So this is the reason why we do the MRI before. Then we put them in traction to see if by pulling the hip you can improve. And then we go for the reduction, which can be closed or
the
open.
problem of reduction was not the acetabular side. It was the short muscles, and it was requiring a lot of pull on the femur to bring it down. So yeah, Vaibhav, show. So we did femoral shortening, to bring the hip in. And, of course we struggled a
my
little
point was that you do the traction before doing the reduction, the traction for a few weeks. This is just to stretch the muscles
how
and
would
see
you
if the hip can go down.
Yeah. So we can discuss this in a separate session, but yeah, let's move on what we did.
So this is a post-op 3-month X-ray. As you can see, the hip is well reduced and there is some ossification of the femoral epiphysis appearing on the left side. The femoral osteotomy is healed well. This is 6-month post-op X-ray. Again, ossification nucleus is starting to appear on the left side. The hip is well reduced, abutting the triradiate cartilage. So
yeah, go ahead. Show the one.
So after 1.5 years post-operatively, this is the final X-ray we have.
So Jayant, what we are seeing, do you think there's an AVN?
Yes.
Yeah.
So we have a this needs long-term follow-up now to make sure that we don't have a proximal femoral growth disturbance, which is very common when you have AVN. So, but I wouldn't consider this a bad result. I think it was a bad hip to start with.
Yeah.
So you would expect some amount of AVN. Hopefully, there won't be too many growth disturbance problems in the future. But this requires follow-up now.
Yeah. So child is walking well. Can you show the next?
Yeah.
Because some of these hips tend to be stiff also. So if you have a good range of movement, I think that's good.
Yeah, so child is doing well, running around, and we'll see. It seems that the GT there's a central AVN, and there are papers that patients younger than 2 years would need like 5 out of 20 of this paper required shortening of femur shortening. So the message is you should not be whenever you go for open reduction in children more than 6 months, keep your plating set ready. If especially on preoperative X-ray you see a higher riding femur, you might need a shortening osteotomy. If the reduction is not very easy, it's very rigid, you have to pull, then do not hesitate to do the shortening. I think we will stop our presentation here. We would like to have a final word with Federico. Thanks for your time. I hope you enjoyed this session. We learned a lot from your final comment from you and Jayant, then we will wind up this session.
So thank you very much for inviting me. It was an interesting discussion, and I was happy to see you, Maulin, again, and to get to know all the other participants. Thank you very much.
Thank you very much. Jayant, a quick word?
Yeah, thank you. I don't know if Federico remembers, but we met in Singapore about 3 years
I
ago.
remember very well now.
Yes.
But because I don't see your face, it's difficult.
So my camera is not working very well. So anyway, so it's good to meet up again. Very nice cases, Maulin, that displayed the entire spectrum of DDH you're likely to see in younger children and the different approaches. So maybe we should